Yeah, so this was a systematic review and meta-analysis of more than 7,000 CAR T-cell patients across 34 studies. A lot of these were real-world studies, but also clinical trials, where we really tried to understand non-relapse mortality. So what is non-relapse mortality? Non-relapse mortality are all events that do not relate to progression of the underlying lymphoma or myeloma, and they encompass oftentimes side effects, but also long-term adverse events of cell therapies. And this is something that we tried to really sort of understand better, and to do that, we sort of went through all the trials and tried to understand really the causes, the specific causes of death that were observed after CAR T-cell therapy. And I think there's several interesting findings, one of them being that there's generally a higher rate of non-relapse mortality in patients that receive brexacaptogene autoleucel for mantle cell lymphoma, and also idacaptogene xyloleucel or ciltacaptogene autoleucel for multiple myeloma. Compared to both LBCL and especially indolent lymphoma. We also observed a higher NRM rate in the patients that received CD28 zeta harboring CAR products as a sort of co-stimulatory domain. And we observed, when we specifically look at the different disease entities, we found that patients receiving axicell compared to tisacel and lysacel had higher NRM, and ciltacel versus idacel for multiple myeloma. Now, one of the major aspects of this analysis was that we really tried to understand the underlying causes that related to NRM, and we found that infections were the major driver of non-relapse mortality after CAR T-cell therapy. They actually accounted for almost 50% of all NRM events, were followed by cardiovascular or respiratory events, and secondary malignancies at about 6%. Interestingly, the more prototypical CAR T side effects, such as CRS, ICANS, and HLH, only really played a minor role in sort of driving NRM after CAR T-cell therapy. So I think there are several clinical implications of this abstract. I think first and foremost, we observed that in the clinical trials, there was actually not a single clinical trial that reported NRM as this typical cumulative incidence function. And we do think that it would be helpful for clinicians to sort of see what are really the causes of NRM after CAR T-cell therapy, and those really being reported both in clinical trials but also in the real world setting. So reporting is one, and then the infections really driving NRM, I think, highlights that we have to perhaps do a better job at identifying which patients are at risk for infections and what we can do to sort of mitigate the risk for severe infections.